Hello, Dentium viewers. Welcome to Dentium Live Surgery. I am Dr. Byoung Kyou, Director of Seoul Pure Dental Clinic. I'm very glad to share my cases with you today. Actually, I'm not a native English speaker, so my English isn't perfect, but I will do my best. I hope you understand. My topic is soft tissue management after large GBR in aesthetic area. So today's patient is a 53 years old female who has been coming for regular checkups. One day she came with her anterior teeth broken due to severe caries. So we had to extract several teeth from tooth number 13 along with the number 22. This is the intraoral photo taken 3 months later. And we took a CT scan to prepare for implant placement. But as you see, the alveolar ridge is very thin. So at this point, I cannot place the implant. So I decided to perform a GBR using titanium mesh. So I raised the full thickness flap and placed the titanium mesh and screw it. And then I packed the bone graft material underneath the titanium mesh and covered it with the collagen membrane and stirred it up with the sutures, closed it up with sutures. And this is the post-op panoramic view, and this is the CT view. As you see, we got plenty of hard tissue as a result. Also, the surgical site healed well without any complication. And 5 months later, I removed the titanium mesh. And this is the current state right before today's surgery. As you can see, we have gained a lot of hard tissue, but the vestibule became very shallow and we've lost some keratinized tissue here. So today, I will be placing 3 bright tissue level implant at the area of number 13 and number 11 and number 22 using digital guide stent and bright Lindemann kit. Additionally, I will perform a soft tissue augmentation using collagen graft 2 as an alternative to free gingival graft. Collagen graft 2 is a soft tissue substitute made from porcine-derived type 1 collagen, and it's commonly used for ridge preservation, and it helps with fast soft tissue healing. And today I will place bright tissue level implant. Although it's slim, it's strong enough, so it's a good option for narrow ridge. That makes the surgery easier. I'm gonna show you similar cases. This patient had severe periodontitis, so we had to pull out multiple teeth. As a result, she got very thin alveolar ridge, so I had performed ridge split and GBL to restore the ridge. Although we got enough hard tissue, but the vestibule became shallow and the keratinized tissue was lost. So I performed the apically positioned flap to deepen the vestibule and secure sufficient keratinized tissue. This is the final restoration. Thanks to the APF, we got a stable and aesthetic soft tissue result. So from now on, we will let's get started today's surgery. All right. Yeah. Now I just placed the guide stent in the mouth, and I'm using the tissue punch drill now. There are 2 sizes of a tissue punch drill, 3.5 and 4.5, and I prefer to use smaller one in anterior area. Now I'm about to remove the soft tissue with a pedestal elevator. As you see at the area of number 11, there is not enough keratinized tissue. Sometimes the remaining removing the remaining tissue is not easy. In that case, you can use mosquito forceps or a back action chisel. Now I place the stent back in the mouth again. When you place the guide stent in the mouth, you should always check that there should be no gap between the teeth and the inner surface of the stent from multiple angles. Now I'm using a flat drill. On irregular bones, it's safer to start with the flat drill so it doesn't slip. And now I'm cleaning the drill site with the saline and switched it to a initial drill, 7mm length. I set it to 1000 RPM. When you use the guide drill, the stopper should fit on passively and tightly on the stent. That way you can drill exactly where you planned. This is the same size, one step longer drill. This is the final drill for today's placement. I'm gonna place 3.0 by 11 length. So in maxilla area, when I place bright tissue level implant, I usually under drill by one size. That way I can get better primary stability. Now I'm preparing the bright tissue level implant. The tip of a bright tissue implant is very sharp, so it naturally follows the drilled site exactly. Now I set it to 20 RPM and placing the implant with holding the guide stent. Well, the stopper is spinning, but it doesn't driving the implant anymore. So something happened there. Since this was a live recording, so I was worried about that. I may lost the primary stability. And I checked the RPM again and trying to place it again, but it doesn't go in anymore. So I eventually removed the adapter and I check it what happened. Switch to a fixed adapter for hand ratchet. Grabbing a hand ratchet, I'm adjusting the final depth manually. Luckily it goes in fine. I think it's well engaged now, as you see. It seems that the fixture must have separated from the fixture adapter during insertion, but it was not a big problem. Now I'm preparing the second implant, the same size, same length. When you use guide surgery, the drill stopper should fit passively and tightly on the stent. That way you can secure the exact drill placement, drilling. Now I'm preparing the last implant. When you use guide stent, implant placement is super easy and very efficient. It's been only 5 minutes, but we placed all implants. And I just removed the guide stent and now I'm removing the plastic cap with a hex driver. When you place or removing something inside the mouth, you should always warn the patient in advance. Something might drop in your mouth, so don't swallow it. Or you can place a piece of gauze over the throat area to block anything from falling in. Now I'm checking the path. Like in this case where we did a lot of GBR, we can place standard sized implant. But in this case, I choose the narrow diameter implant because the graft GBR bone tends to resorb over time, so it's better to leave more hard tissue on the buccal side of the implant. So I prefer to use the bright tissue level implant in the anterior region. I'm going to use digital abutment. Each digital abutment comes with a plastic cap and a screw. That plastic cap is a handle to connect the abutment to the fixture. But in this case, I'm gonna remove it, and then I will connect the abutment to the temporary bridge first. Because when you place multiple implants in the anterior maxillar area, the implant, the path is not parallel. So if you connect the abutment to the implant first and then try to connect the temporary bridge, you cannot connect it. The path of implant is different. But thanks to the bright tissue level implant, it has a specific structure at the top, similar to multi-unit abutment. It allows for up to 20 degrees of divergence. So even if the implants are not parallel, you can still connect the bridge. I think the implant placement was very precise, so I can connect it now. Now I'm tightening the temporary bridge with a screw. If one of the implant was misaligned, placed in wrong position, we cannot connect the temporary bridge. But in this case, the implant placement was perfect, so I could connect the temporary bridge, which made it earlier while I planning the guide stand. Now I'm tightening the abutment screw. For provisional, I usually go with 15 to 20 Newton. And for the final restoration, I usually torque it to around 30 Newton. That gives a strong fixation without deforming the screw. Now I'm taking a photo, intraoral photo, and it's very fast and efficient. We already placed 3 implants and connected the temporary bridge. We can finish the surgery at this point, but if I leave it like this, the patient might feel discomfort while brushing. So as you see, the vestibule became shallow and there's no keratinitis around the tooth number 11 area. Now I'm checking the occlusion. Because of the large GBR, I pulled the buccal flap coronally to close it, so the vestibule became very shallow now. So now I'm going to perform a mucogingival surgery, kind of like free gingival graft, but instead of harvesting the free gingiva from the patient palate, I'm going to use collagen graft material, collagen graft 2, which is a soft tissue substitute. And I asked the camera director that am I blocking the camera view, and she answered yes. But anyway, I went ahead to make the incision because it's convenient. Because of the large GBR, when I make an incision, I usually use the buccal flap coronary motion. So due to the camera angle, I tried to use the blade with the pushing motion, but it's very hard. Now I'm raising the buccal flap. So with a pushing motion, going to perform a mucogingival surgery, kind of like free gingival graft, but instead of harvesting the new blade from the patient palate, if you feel that the blade is getting dull, don't hesitate to change it. Too. I usually use 3 or 4 blades in one mucogingival surgery. And I asked the camera director that I'm thinking about blocking the camera view, and actually when we record this video, anyway, we used 2 cameras, main camera and sub camera, because it's convenient. The footage you are watching is from when I make an incision, I usually use the blade with the pulling motion, but main camera. Due to the camera angle, so now I tried to using the blade pushing motion, but it's very hard. Motion. It's quite difficult. Now I'm but you don't need the buccal flap. Use the blade with the pushing motion. because you don't need pushing motion. Think about the camera. And I just asked for new blade. And when you raising the buckle flap, if you feel keep the blade keeps getting dull, don't hesitate to change it. I usually use 3 or 4 in this case, in one the alveolar ridge is uneven, surgery, so it's not easy to raise it. I just changed to a new blade, and I'm thinking about the camera angle. Actually, when we record this video surgery, we used 2 cameras. When you make the main camera and sub camera, you should leave the only footage you are watching is from the sub camera. But in reality, it's not easy to do that. So we leave a bit of connective tissue along the periosteum. So now I'm using the blade with the pushing motion. It's quite difficult, but you don't need to use the blade with the pushing motion because you don't need to think about the camera. To avoid tissue damage, I frequently irrigate, and when you raise the buccal side with the saline, please keep the blade parallel to the outer contour of the alveolar ridge. But in this case, the alveolar ridge is uneven, so it's not easy to raise it. I just changed to a new blade 50 suture material to fix the buccal flap apically. When you make the partial thickness flap, you should leave the only periosteum. But in reality, it's not easy to do that, so we leave a bit of connective tissue along the periosteum. To avoid tissue damage, now I'm about to fix the buccal flap apically, irrigate the surgical site with the saline. The retractor is so annoying. And I'm checking the vestibular depths now. I'm placing it back again. And I asked 50 suture material to fix the buccal flap apically. When you suture the buccal flap, start at the center. If you start from one side, it might shift or wrinkle by the time you reach the other. So starting at the center is very important for symmetry. Now I'm making a surgeon's knot. Now I'm about to fix the buccal flap apically. The retractor is so annoying. It just popped out. When you place sutures deep in the vestibule, usually I'm placing buried again. So leave the material, the tail longer than usual, or observing the suture material is recommended. It's not easy to remove the suture later. Now when you suture the buccal flap, start at the center. If you start from one side, going from outer area of the buccal flap by the time you reach the other periosteum, and then so starting at the center is very important. Coming out symmetry from inner surface of the buccal flap to outer surface. Now I'm making a surgeon's knot. That is horizontal matrix suture. When you place with just a single stitch sutures deep in the vestibule, I can secure a wide area of the buccal flap. So I love to use this suturing technique. So leave the material, the tail longer than usual, or to avoid tissue damage, or observing the material is recommended. The area with styling again, and now I'm suturing the corner where I made a vertical incision. Now I'm just trying to make a horizontal matrix suture, makes it easy to finish. Flap. Going from outer area of the curry longer than you think, and passing through the periosteum, and we move to the other side, coming out from inner surface of the buccal flap to outer surface. That is horizontal matrix suture. The instrument I'm using is called cone plier, which has a hole in the center, which helps guide the needle exactly where I want it to go. With just a single stitch, this is very useful. I can secure a wide area, especially in buccal surgery. I love to use this suturing technique. Now I'm making another horizontal matrix suture, passing through the periosteum. Tissue damage. I'm flashing the area with styling again, and now I'm suturing the corner where I made a vertical incision. When you pass through the periosteum, you should rotate the needle. Makes it easier to finish along the curve of needle. If you push it too hard, cut it longer than you think, the needle can bend. Or worse, you might tear the periosteum the other side. So always follow the arc of the needle. This is very important. Now I'm making a knot to finish the horizontal matrix suture. Flushing again. The instrument I'm using is called cone plier, which has a hole in the center, which helps guide the needle exactly where I want it to go. So this is a very useful instrument, especially in buccal surgery. Now I'm making another horizontal matrix suture, passing through the periosteum, the buccal flap. The retractor was so annoying, so I just took it out. When you pass through the periosteum, you should rotate the needle along the curve of the needle. The cone plier is very helpful. The needle can bend. Now I'm making another. You might tear the periosteum, so always follow gently the arc of the needle. This is very important. Now I'm making a knot comes out to finish the horizontal matrix suture. This is the horizontal matrix suture. Flushing again. Almost done. And I can finish the surgery at this point, but now
If
if
I
I
leave
leave
it
it
like
like
this,
this, the exposed tissue may become thin, so I'm going to use crutch and graft. The retractor was so annoying, so I just took it out. The reason why I do not use the free gingival graft in aesthetic area is color difference. The palette free gingival graft is very helpful. It's a bit brighter than the tissue around the teeth, so I don't use free gingival graft in aesthetic areas. Instead, I usually use
gently rotate the needle.
Now I'm going to fix the collagen. This is
graft
the horizontal matrix suture, and this time I'm using vertical inverting matrix suture.
Almost done.
It helps a lot if the assistant holds the graft material while I suture. So I'm suturing, but my assistant is busy
I can't
now. Finish the surgery at
Because
this point. This was her first. If I leave it like this, the exposed tissue may become thin, so I'm going to use crutch and graft too. The reason why I do not use the free gingival graft in aesthetic area is color difference. The palette free gingival graft is
Now I'm making
a bit brighter than the tissue around the
clockwise
teeth, so
and one counterclockwise.
I don't use free gingival graft in aesthetic areas. Instead, I usually use collagen graft too. As you see, with a single matrix suture, the collagen now I'm going to very stable now. Fix the collagen graft too.
Almost done.
And this time I'm using vertical inverting matrix suture. The other side, same way. It helps a lot if the assistant holds the graft material while I suture. So I'm suturing, but my assistant is busy now because this was her first assistant. I just placed the collagen graft 2 on the recipient bed. She's blocking the camera. Now I'm making a knot. I'm going to use
clockwise
vertical
and one
counterclockwise.
suture.
As you see, with a single matrix suture, as I told you before earlier, rotate the needle gently, very stable now, or not you might tear the periosteum.
Almost done.
The other side, same way. I just placed the collagen graft 2. Sometimes people ask me recipient bed about the collagen graft 2, whether it has a front and back. It has dense zone and loose zone, but it doesn't matter which side you place on top. Same way, I'm going to use vertical inverting matrix suture. The collagen graft absorbs the blood pretty well. Looks nice. As I told you before earlier, rotate the needle gently, or not you might tear the periosteum.
For the camera view, I place the retractor back in the mouse again. Sometimes people ask me about the collagen graft 2, whether it has a front and back. Collagen graft it has dense zone and loose zone, but so it doesn't matter which side you place to match the bed. The collagen graft absorbs the blood with a pretty well. Looks nice. Almost done. Now I'm stirring at the corner, stitching it to adjacent tissue. Makes it easy to finish. For the camera view, I place the retractor. Simple interrupt to the mouse again. Here. I think the collagen graft 2 is a bit big, so now I'm trimming it to match the bed. The last stitcher, same way. To fix the graft material, I used only 2 stitches, which is really efficient. Almost done. So I love the horizontal matrix suture and vertical matrix suture. Alright, we just finished today's surgery, and as I mentioned, we recorded this surgery a few weeks ago. Now I'm showing the result at the corner of today's surgery, and I think many people are curious about how it turned out. Makes it easy to finish. I brought the result. Let me show you. This is the post-op panoramic view. All implants were placed here as I planned, and as you can see, the recipient bed is nicely covered by collagen graft 2. But unfortunately, the graft got slightly folded around the tooth number 21. But it's not a big problem because the rib will naturally press it down, so it will heal well. The last stitcher, don't worry about it. And all implants were placed to fix the graft material. I used only 2 stitches, leaving 1 millimeter of lingual bone and efficient, more than 2 millimeter of buccal bone. So I love the horizontal matrix suture. One day after the surgery. As you see, epithelial cells are starting to we just finished today's surgery material. And you can see, as I mentioned, we recorded this surgery a few weeks ago to share the result, and this is today's result. 2 weeks. I think many people later, many people are curious about the vestibule was very shallow, but now you can see deepen the vestibule, and let me show you. Also, you can see this is the post-op panoramic view. All implants were placed as I planned, and as you even see, if you can feel uncomfortable, is nicely covered by graft. This technique, unfortunately, can be a good alternative. The graft got slightly folded around the tooth number 21. Now let's have but it's not a big problem because the rib will naturally press it down. What considerations should be taken into account? Don't worry positioning about it. And flap apically all implants were placed exactly where I planned. First of all, I think I had planned and leaving the incision position. 1 millimeter incision position is very important. So if there is any remaining cartilage tissue, it's best to make the incision right one day after the surgery. So in that way, as you can secure epithelial cells are starting to migrate. If you don't have enough keratinized tissue, then you should consider that nice pink color coming in instead of really good early position graft. But I don't like to use fridge graft in aesthetic area because, as I told you earlier, the color of the palate is very shallow, but now the tissue color around the teeth is different. So also you can see when you place the fridge graft on the anterior area, it stands out. It causes aesthetic problems. As we can see, if you feel uncomfortable, especially in aesthetic area, I love to use this technique. Can be a good alternative treatment option. I wish that answered your question. Now let's have a Q&A session. Alright, that's it for now. Here's the question. Thank you for watching Dentium live surgery, and our next live surgery will be June 6th at 7 p.m. I hope this surgery was helpful for your clinical practice, and enjoy the rest of your night. Stay tuned. Thank you.